Could I ask Rick and Merrilee to come up, and also Peter? Just have a group session. So we've sort of had a top-down presentation or presentations on inventory management, right down to small private health providers. So I open the floor up to questions to our panel. Peter.
I really wanted to ask Rick when he first developed his love of shippers, but I won't. Probably should be done after a glass of wine, I think. Peter, it's hard to imagine an industry that will tolerate 20% of a product it makes being thrown out. The platelet expiry is extraordinary. How does that compare to international comparisons?
Look, it does. There are some comparators, but to be honest, we haven't expressed them for platelets, particularly given the distances in Australia. If you look at, say, the UK, which is often where people compare for discard rates, we are a lot higher than they are for platelets. But the fundamental distances for travel, so for example, if you're taking a platelet to, I don't know, Alice Springs, it's only got 3-4 days to live when it gets there. The cost of getting the platelet into that site to then get it rotated out to somewhere else that might be able to use it is probably more per single shipper to transport that shipper on a plane than it is for someone to stick somebody physically in the seat on the plane and fly it out. And so the problems we have here in Australia with the distance, with the remoteness of some of our sites where they do need to hold a small stock of platelets, but over time if they're discarding 80-90% of those because they're not often required, does make it problematic. Also, we see a lot of remote sites are holding platelets where it's often the outcome of a coroner's finding. In the past, something terrible has happened. Coroners' courts have handed down a decision, you must hold platelets here, you must hold red cells here, and so forth. 20 years later, they're still being held there and they've never been used in the last 20 years. So we don't really make international comparisons on the platelet wastage yet. Longer term, I think it's something we could do, but I think we also need to recognise that there are different issues in Australia, particularly for those very short shelf life products like platelets, where compared to, say, red blood cells, I'd argue in many cases we could compare ourselves internationally where we're not doing too badly.
But there are some sites that you clearly could compare. I mean, the Royal Adelaide's got a platelet wastage of 15%, I think. And you know, other than the fact that somebody in their wisdom decided to have all of our product harvested here and sent to Victoria and flown back, I don't think that explains all of that. But why could you not benchmark with the major sites, for instance, and shouldn't we be doing that?
And I think the answer is yes, we should. We've started doing that, but we haven't actually released any of that data publicly yet. Being brutally honest, what we're trying to do is raise people's awareness now so they can improve their practice before we publish benchmarking data showing in some cases how poorly perhaps some of our sites are doing. At the moment, we're trying to celebrate the sites that are doing well, but there are a lot that aren't. The wastage reports that are coming out from BloodNet in the next week or so actually now will enable hospitals to benchmark themselves at least across compared to the state discard rates, the national discard rates, and against their peer groups. So that's the first step down that path. But there was strong resistance in the last 12-18 months to people being benchmarked internationally or against one another. We've been trying to get people comfortable with the idea that you can tackle discards, you can improve what you're doing. Benchmarking, however, is starting to come. The first lot of data you'll see will be next week.
Yep.
Thanks for the talks. I was just wondering, we see a lot of this focused on expiry rather than clinical waste within hospitals. Is there any plan to actually better be able to monitor the reasons for hospital clinical waste? When I'm saying taking out to the ward, somebody has cardiac arrest, we can't use the product, we discard, versus taken out, sitting on a bench for 2 hours, a lack of staffing. Is there going to be any way that we can then have an audit process within nationally that filters into BloodNet the reasons for non-expiry clinical waste? Because that's the bit that most of us have to deal with, and we don't do it that well sometimes.
Feeling terrible I'm answering all the questions so far. The short answer is yes, that data is actually collected now. So individual laboratories can actually analyse that data now. At this point in time nationally, we haven't done a great deal about it purely because it is a very small proportion of the waste overall. When we can deal with the time expiry in a better way, we'll move on to those areas, but being inherently, I suppose, we're going for the low-hanging fruit. If we can tackle some of the time expiry issues, then we can deal with those issues. There are some aberrations, I suppose. For example, there's often a lot of advice we get in terms of people implementing the massive transfusion protocol often generates significant waste for FFP because everything happens, people start thawing it out, patient doesn't need it, whatever happens, the MTP's called off. Then there's an issue with that, and so we're seeing across the country some sites are tweaking how they're doing their massive transfusion protocols and exactly what's in those packs and what's not. But we're still seeing the overall rate of discards due to clinical reasons or damage on the ward or being left out, hospital porter gets dragged off to do something else, is still a very small proportion of the overall waste. So we will tackle it, but we're aiming for the big wins first.
We had some very interesting figures that Trish brought out about a doctor who wouldn't change even though he was confronted with staggering statistics that showed that he didn't need to be doing what he was doing. So what power have you got to bring this to the attention of a user who, just for the sake of being absolutely careful and probably wanting to do the very best by his patient, but is going beyond, it would seem, in a built-up area hospital with facilities of blood supply from quite close by, why does he, if it doesn't need to be shifted or it's being shifted out and shifted back repeatedly, you'd have to ask that chap, does he group and match his wife and kids when he drives to Port Augusta and take it in the boot? and what power does the National Blood Authority have, what authority is there to actually say that your practice is very much as an outlier and you're being over-conservative, over-careful, over-wonderful care consciousness for your patient, but this is provided at cost?
No, let the rest of the panel members answer. Peter?
Deal with I think just
We have no power for that.
That's the same for the NBA. No.
I think just the
present the
constant
statistics.
representing the information. I mean, we did present the ANZ SBT maximum blood order schedule, which, you know, is a bit outdated and doesn't really always reflect current practice. But that did say for hips, I think cross-match 3 units still, but group and save for knees. So that information was provided. And I guess sometimes I think, well, what's the problem? Because we're not wasting the blood because the laboratories do take it back. I guess continually providing the information about inventory management and efficiency of use. And I believe that surgeon doesn't work there, so I don't think we put any more effort into it anymore.
Yeah, I'll just say, just try education, reassuring that the blood can be supplied if it's needed, having an emergency ONEG supply that is rotated there in case the procedure goes pear-shaped. So just continually at it and peer pressure wherever we can.
I also think the biggest step forward for the private sector will be if we can get data linkage like the public sector has, so surgeons can know easily what their transfusion rates are. At the moment it's a very tedious process and we're just starting it with another hospital, but you can only really give them snapshots of their transfusion rates. We don't have the ability to sort of link it up, but that would be a great step forward, and then surgeons would know the transfusion rates and maybe some competitiveness would come out as well.
If I could just comment from a country point of view, I think the problem that we're talking about at the moment is actually worse in country areas because you have visiting surgeons who cross-match blood, who ask for cross-match blood, and the resources, of course, and the ability to return it is not quite as good as it is in the city.
Thank you. Response? Yep. Do you want to answer just through the microphone, Trish?
We didn't investigate it because it was changed on the day, so the practices were changed. But presumably, I don't think it's an uncommon practice that people in the rooms will help out, whether they've got pre-standing orders or it's established practice for a while. So maybe it wasn't highlighted as something that had been something that had been carried on for some time.
Are they using consent forms, transfusion specific consent forms, or is transfusion mentioned in the consent form for procedural?
Pretty well, most of them consent is in the operative consent form in the private sector that you'd normally have to opt out, so consent blood transfusions if medically indicated, or there's an extra section on consent in some of them. They all have a different forms, but it's included in all the surgical consent forms.
Okay. Well, one more question. The lady's been trying there for a while.
I guess the last two issues are around good governance. So any culture has to comply with the relevant policies of the organisation and the instructions accordingly. So this is where, picking up on Peter's presentation, in terms of, yes, we have a governance structure, but governance is there for a reason, governing. So no one can be unique within their own rights if it's going to impact on potential patient care and clinical outcome. So governance is another way, including providing good data to change practice, but it's also you practice in this organisation, you comply with the policy process that's required. So I just throw that in because I think we've talked about governance and where that can play a very pivotal role in patient safety.
Thank you. Probably just bring that to close with one final question. As has been highlighted, South Australia is leading the country in terms of reducing wastage. And my question to the three, other than the NBA panellists, is how low do you think you can go? Given you're already setting the benchmark, okay. How low do you think you've got to go?
I'll add on to whatever she says.
Yeah, I'm hoping that we'll get, the lowest we've gotten per month is down to 1 unit wastage. I'm hoping to get to the 0. That's what we're aiming for at all the sites to rotate. And as a result of the fact that we've started rotating, we've actually, as a transfusion committee, we've reassessed where we hold our emergency stock and put it in a few more sites so that then the surgeons aren't ordering in that extra blood from there.
So just that, whenever, even if there was 1 unit wasted, we'll investigate that and see what we can do. Because I think when everyone sees that we're actually looking after the pennies, the pounds look after themselves.
Fantastic. Can you do it on the top? On behalf of everyone here, it's great. This is what it's all about. This is the show, but these are people doing it and actually achieving results. On behalf of everyone here, thank you very much for your presentation. Trish? Rick? Merrilee.